Well, after understanding the forearm muscles, in the flexor compartment, you have the pronator teres, the pronator quadratus, the supinator, and the biceps, working on the axis of supination and pronation. Then you have the flexor carpi radialis and ulnaris, and extensor carpi radialis longus brevis and ulnaris, acting on palmar flexion of wrist, dorsiflexion of wrist, radial deviation of wrist, and ulnar deviation. Then you have MP flexor and PIP DIP extensor, and the muscle here is lumbricals or musician's muscle. Then you have MP extensor, which is extensor digitorum, supported by extensor indicis on the index finger side and extensor digiti minimi on the little finger side. Then you have muscles of the pollex, abductor pollicis longus and brevis, extensor pollicis longus and brevis, flexor pollicis longus and brevis, adductor pollicis, and opponens pollicis and digiti minimi. So after just naming these muscles, we draw the diagram of the hand, and you must learn to draw it in this sequence. The first metacarpal, the second, the third, the fourth, and the fifth. Then the palmar and the dorsal interossei. So first the dorsal interossei, 4 in number, and the palmar interossei, 3 in number. In the first web space, there is no palmar interosseus. Then the adductor pollicis. Then the 3 muscles, the opponens, the flexor, the abductor pollicis, brevis, abductor pollicis brevis, flexor pollicis brevis, and opponens, which will rotate this metacarpal, which opponents would rotate this metacarpal. Similarly, you have opponens, flexor, and abductor digiti minimi. Opponens, flexor, and abductor digiti minimi. Then on this basic structure, you place the palmar aponeurosis and you drop a septum to the third This becomes the thenar space. This becomes the mid-palmar space. This becomes the adductor space. Now, you place the long tendons of the flexor group in this. So, palmaris longus is the one that forms the palmar aponeurosis. So, this palmar aponeurosis is the extension of palmaris longus. And here, of course, you would have the flexor pollicis longus, the four tendons of the flexor digitorum superficialis, and the four tendons of the flexor digitorum profundus, deep. Here will be the deep fascia covering this. And here would be the palmaris brevis muscle. So this is the palmaris brevis, which is in the subcutaneous tissue. Therefore, it is also called as panniculus cornosus. Then we place the muscles on the extensor side. So this is the abductor pollicis brevis. Here is the abductor pollicis longus. And of course, you have the extensor pollicis brevis here. The longus would come from this side. So here you have the extensor pollicis longus. Then the muscles of the carpus, the extensor carpi radialis longus, the extensor carpi radialis brevis, the extensor indicis, the four digitorum, the extensor digiti minimi, and of course here you have the extensor carpi ulnaris. So then you have the extensor indices, the four tendons of the extensor digitorum, and extensor digiti minimi on this side, and extensor carpi ulnaris. So once you learn to draw this diagram, you know the section of the hand and you know the complete anatomy of the section of the hand. Now, after this, let us talk about the nerves, because we are starting to talk about the paralytic hand. So, here is the axillary artery converting into the brachial artery. And here will be the brachial plexus. So, you have the lateral cord, the medial cord, and if you make the blood vessel here, here you have the posterior cord. The lateral, the medial and the posterior. The lateral and medial cord, the lateral cord will continue as the musculocutaneous nerve. The medial cord will continue as the ulnar nerve. And the posterior cord will continue as the radial nerve. From the medial and the lateral cord would arise the median nerve. So, 4 nerves, 3 cords. Lateral, lateral, posterior, medial cord, and the four terminal nerves being musculocutaneous, median, radial, and ulnar. So this is the artery. Anterior to it, the median nerve, posterior to it, the radial nerve, lateral to it, the musculocutaneous, and medial to it, the ulnar. After understanding this much, you understand that there is a lateral and medial pectoral from the lateral and medial cord, and from the medial cord there is the medial cutaneous nerve of arm and forearm. From the posterior cord you have the upper and the lower subscapular, which supplies the subscapularis muscle. The nerve to latissimus dorsi. Subscapularis, the nerve to latissimus dorsi. And then you have the axillary nerve, which supplies teres minor and deltoid. I am sorry, you will have to remember this origin of nerves in this manner. Now we will trace for you the four nerves. First, the musculocutaneous. Arises as a continuation of lateral cord. Lies on lateral side of artery. You see, if this is the artery, here will be the coracobrachialis muscle. The nerve is lying here on the lateral side of the artery. It will pierce the coracobrachialis, lie between the biceps and brachialis, lie between biceps and brachialis, emerge on the lateral side. So let us say here, it will pierce, supply coracobrachialis, lie between biceps and brachialis, then between biceps and brachioradialis, pierce the deep fascia, become lateral cutaneous nerve of forearm. You see, that's why the musculocutaneous supplies biceps, brachialis, coracobrachialis, some fibers to brachioradialis. That's the muscular portion and becomes the lateral cutaneous nerve of forearm. Typically involved in Erb's palsy. Therefore, in Erb's palsy, you have to restore shoulder abduction by trapezius transfer, and you have to restore elbow we do it by transferring the pectoralis minor to biceps. So this is about the musculocutaneous nerve. Then we talk about the median nerve. Arises from lateral and medial cord, lies lateral to artery, crosses artery to become medial to it in middle of arm, crosses elbow. Now what happens in elbow? In elbow, this is the lateral epicondyle, the capitulum, the trochlea, the medial epicondyle. Here you have the radius, here you have the ulna. So the first thing this nerve encounters is a muscle called pronator teres. So pronator teres would go and get inserted onto the radius. It will go and get inserted onto the radius arising from the humerus, and it has got a ulnar head which is arising from the coronoid. So the nerve, this is the artery coming, is dividing into the radial and the ulnar. Ulnar will pass like this, deep to the ulnar head of pronator teres. And here is the nerve coming on the medial side of the artery. And this nerve will pass between the two heads of the pronator teres. So when you have to do a pronator release in Max Page operation, first you will have to remove the humeral head of the pronator teres, then save the nerve, and then remove the ulnar head of the pronator teres, saving the ulnar artery. Then this ulnar artery would give an anti-intraosseous artery, which is an end artery. And the nerve will lie parallel to this artery on the interosseous membrane, lined on this side by flexor pollicis longus and this side by flexor digitorum profundus. So in Walkman's ischemic contracture, there develops, because this is an end artery, there develops an infarct. There develops an infarct. You cover this infarct here. So there develops an infarct in this region, an elliptical infarct, because this is an end artery and this entraps the nerve. So there is a infarct in VIC which entraps the nerve and this has to be decompressed in what is called as the Seddon's operation. So then after this understanding that the nerve passes between the two heads of the pronator teres, then it passes under the two heads of flexor digitorum superficialis, under it, lying between flexor pollicis longus and flexor digitorum profundus, accompanied and supplied by the anterior interosseous artery, which is involved in chronic VIC, leading to necrobiosis and an elliptical infarct in the muscle, which entraps the nerve and must be released in an operation which is called as Seddon's operation. Now, after this, we'll make a hand. This is the thumb. Here is the abductor pollicis, the flexor pollicis, and the opponens pollicis. All right. So here will be the abductor digiti minimi, the flexor digiti minimi, and the opponens digiti minimi. And they will be connected by a retinaculum, which is the flexor retinaculum. So this nerve is coming here. On this side you have the flexor carpi radialis, and on this side you have the palmaris longus tendon, which will become the palmar aponeurosis. So here is the palmaris longus. So the nerve is coming here. So 5 centimeters above the wrist. It gives a palmar carpal branch, which supplies the lateral 2/3 of palm skin. So this is the palmar carpal branch. After this, it passes under the carpal ligament, or which is also called as the flexor retinaculum, and this is called as the carpal tunnel. So it can get pressed in the carpal tunnel and can be decompressed by dividing this flexor retinaculum. But the incision that you would make in the fascia would always be medial to the palmaris longus tendon to avoid damage to the nerve. So this is how you do a carpal tunnel decompression. After passing through the carpal tunnel, it divides into a superficial branch which supplies 3.5 fingers, 3.5 fingers. So it divides into, after the carpal tunnel, superficial branch supplying 3.5 fingers, and a deep branch which passes between abductor and flexor pollicis brevis, supplies the opponents and ends in the lateral two lumbricals. So then there is a deep branch which passes between abductor and flexor pollicis brevis, pierces and supplies the opponent's pollicis, and ends in lumbrical 1 and 2. So now, in the forearm, this nerve will supply all flexors except flexor carpi ulnaris and flexor digitorum profundus of third and the fourth. So, if there is a paralysis at the level of the elbow, which is called as high paralysis, then FDP and FDS would be paralyzed. But the FDP 1, 2 will be paralyzed, but 3, 4 will be saved because it is supplied by the ulnar nerve. And this 3, 4, since the third one will give a branch, third one will give a branch to second also, therefore the second, third and fourth will flex. You see, this is the thumb. Only this will remain extended, all the rest will be able to flex. And this is called as pointing index sign, which indicates the paralysis of the median nerve at the level of the elbow. So, in the forearm, we have told you how to release it in the max page operation when it passes between the pronator teres, how to decompress it in the elliptical infarct which forms between the flexor pollicis longus and flexor digitorum profundus, called the Seddon's operation, how to decompress it in the carpal tunnel, and we tell you that any injury of the nerve above the wrist will cause the pointing index sign, pointing index test. Below, we test we put a pen here and ask him to abduct the little finger, the thumb, to touch the tip of the pen. This is called as the pen test. And this is testing the abductor pollicis brevis. So these are the signs of the high and the low paralysis. Now, how would you manage a median nerve problem? So manage the cause, management during recovery, can monitor the recovery by March phenomenon, by Tinel sign, and by electrodiagnostic tests like strength duration curve, nerve conduction velocity, strength duration curve, or electromyography. So you monitor recovery. Then you maintain muscle tone, first by galvanic stimulation, then by Paralytic, because galvanic stimulates the muscle, large duration current stimulates the muscle directly, the short duration current which only stimulates the nerve. Then you have active assisted, active only, and active resisted exercises. So, active exercises, and when there is residual paralysis, you substitute the opponent's muscle. Operation is called as opponent's plasty. Now this opponent's plasty is basically trying to restore opponence or rotation of this metacarpal, because this muscle opponence is inserted on the outer border of this first metacarpal. It rotates the metacarpal in this manner. Basically, abductor pollicis brevis is the receiving muscle. Abductor pollicis brevis or extensor pollicis brevis. These are the muscles that have to be restored. So one way to restore them is that you take the FDS. This is the FDP, this is the FDS dividing into slip. So you take this FDS, you take it around the ulna, take it around the subcutaneous fat or a pulley in the flexor carpi ulnaris, and insert it onto the abductor or around the first metacarpal. So these two operations are called as Riordan's or Brand's operation. But the most important thing is, before this operation, the carpometacarpal joint must be painless and stable, and there must be an adequate first web space. So first you must achieve these before you plan to this Riordan operation. So this is what is called as a fixed origin transfer. Then there is a fixed insertion transfer. Where you take the tendon of the extensor pollicis brevis. And this extensor pollicis brevis tendon you can put the extensor carpi radialis longus, extensor carpi radialis brevis or extensor indicis or extensor carpi ulnaris and even flexor carpi ulnaris. All these can be fed into the extensor pollicis brevis tendon as it is cut from the muscle tendon insertion here and rerouted around the wrist so that it starts rotating the thumb outwards. And any of these tendons can be used as motor for it. Motor can be flexor carpi radialis, palmaris longus, flexor carpi ulnaris, extensor digiti minimi, and any of these motors can be used. Many motors can be used in this fixed insertion transfer, and the operation is called as Phelan-Miller procedure. Finally, you can use the abductor digiti minimi for the abductor pollicis. You can transfer the insertion of this onto the insertion of this. Rotate it and transfer. This operation is an intrinsic transfer for opponents, and it is called as Littler's procedure. We covered the median nerve, we'll cover the ulnar nerve later. Thank you.